In. So thank you to everyone for joining. As you guys know, the topic of the session today is about COVID and cancer and the mental health components for healthcare workers. And the main objectives which we'd circulated are discussing the mental health challenges that cancer care providers and other healthcare workers have faced as a result of the COVID-19 pandemic, as well as discussing coping strategies and ways to mitigate these mental health challenges in the setting of this pandemic, but also thinking about future things that might occur. So we have two excellent speakers today, and I'm really excited that they were able to join us. I'll give brief introductions for both of them, and then we'll have the speakers go in tandem for about 10 to 15 minutes. So our first speaker is Dr. Datta, who is a senior consultant psychiatrist at the Department of Palliative Care and Psycho-Oncology at Tata Memorial Center in India. He's also an honorary senior research fellow at the MRC Clinical Trials Unit, the Institute of Clinical Trials and Methodology at the University College London. He's a palliative care specialist and has several publications on mental health of healthcare workers. And our second speaker is Dr. Amar Edwin, who is joining us from Ghana. So she's a physician, psychologist, bioethicist, and palliative care provider at the University of Ghana Medical Center. So Dr. Datta will go first with the didactic, sort of setting the stage for this topic, and Dr. Edwin will sort of drill down into some of the strategies that she and her team have used in Ghana. So, as always, we'll want this to be interactive. We'll have a period for questions and comments at the end. And if folks have comments in between, you can also type in the chat as well. So I will pass it on to the speakers now. Thank you.
Thank you so much, Dr. Datta, for that kind introduction. Hi, I'm Shomitro, and I would talk about around for 15 minutes about what we did during the first and the second wave of the pandemic in Kolkata. So there are two Tata centers in India. One is in Kolkata, one is in Mumbai. Ours is the newer and the younger one. So I'll start with a secret. The most difficult part of my job was to be able to tell everybody that you don't need to worry, and while I was myself quite worried. So because psychiatrists are also human beings, and that's what represents the fear, anxiety which we all went through in the beginning of the pandemic and again in the second wave of the pandemic. So how did we survive, and did we survive psychologically and physically? If you talk about the differences between pre-COVID time and COVID times, unfortunately, that's how life is divided. People feel that staff are healthy and patients are unhealthy. Of course, perfect health is utopian, so staff also have physical and mental health issues. Young versus old, cancer happens often to older patients, older parts of the population, although young cancer is quite common nowadays. And cure versus palliation, that's again a dichotomy which the oncology world looks into with the intention of treatment. And in Lancet Oncology, the published data from India shows that 70% of cancer patients are dead by 5 years. And maybe people can't afford the treatment, maybe they present quite late, maybe we don't have adequate screening facilities, maybe there is not adequate health infrastructure around the country. India is a very big country. So although there is this situation where fantastic outcomes of some of the cancers like childhood leukemia and all in the West, but some of the low and middle income countries are lagging behind, and we often try to not face the reality of it. And being a doctor in a palliative care and psycho-oncology department, which I had set up around 10 years ago, I realized that life is not that simple like us versus them. And this had hit in a big way during the pandemic. Now, some of the photographs I would be showing, this is an art of medicine project I have shared in the handout, web link. So this was, like artists do. The door had broken, and somebody had put in this notice, locked, and so that people don't break the handle. And this child with the mother is looking outside, and that's how patients felt when they had cancer and chemotherapy and not being able to play outside. And that's how we felt when we were under the influence of this lockdown, which was in the month of April, May into 2020 in India, where suddenly life came to a standstill. So traveling was inconvenient. Some of the staff, I stay very near to the hospital. In fact, I'll tell you something which I did. After I returned from India, traffic was so bad. For 10 years, I did not drive, but I started driving because I had to in these in during the pandemic, and I'm continuing that. So life changed, and there was scarcity of PPE. People were worried about this ever-changing version of truth because we didn't know what was happening and what are the best ways to act. And it was not helped by the fact that there were retractions in internationally well-reputed journals about what could be done, things like that. So post-truth about that and all the complexities around it increased anxiety a lot. There was personally, most staff were vulnerable, anxious, and work-life balance had affected the amount of work you could do in a team which is fully available in a hospital. Often people were doing shift work, so that changed. The first challenge, and when we dealt with the impact of quarantine, I think many of the staff were provided accommodation if they lived far away, and there was hospital transport and some other factors which we did phone a friend, sort of looking into their needs, and the same things which probably worked around the world. This is a Lancet review about what could work. The second worry was, will I get infected? And I have a very interesting story here, because healthcare workers were a high risk group, and this was overwhelmingly a new challenge. I have worked in forensic settings in England. I don't think I went into the forensic ward ever thinking that my patient would hit me. But this situation of a pandemic was that not anybody would do it purposefully, but I might suddenly get infected because of an unintended exposure. And this we realized very early on in Tata Medical Center was causing a lot of anxiety within staff. The staff whom we met, we realized that they were worried about themselves and their home and carrying the infection back home. One of the steps which we did was we created this thing called Green Corridor, and this is, we have published this in the JCO Global Oncology. So, patients with COVID did not come into the hospital and said, I have COVID. So patients with cancer came into the hospital and they might have fever, and they may be potentially having COVID. So as soon as such patients were identified, there was something like code blue, like you have a cardiac arrest and the code blue team comes. So we had a code green, and we designated certain pathways. So from the OPD to the isolation area. This is not, mind you, the isolation ward. This is an isolation area. If in the later part of the pandemic, when rapid test was available, many of the suspected patients actually did not turn out to be COVID positive. But at least staff by their mind knew that they are not sort of suddenly being exposed to COVID infection just because they're working in a hospital. So there was designated areas. And staff, this did not only involve, a hospital can't run only with doctors and nurses. So this is a picture of the kitchen staff with food handlers. So COVID spreads through saliva, and our food handlers, so myself and the other psychiatrists and the microbiology and infectious disease team, we had actually met in small groups in an open air area, maintaining social distance with masks on, and addressed each of the anxieties of the staff, particular group, depending on what they did. So food handlers were worried about the saliva spreading the infection. So we had used disposable cups and plates which the patients were taking, and they were incinerated. And the food handler was not expected to go inside the isolation room, so they just left the food outside the COVID ward, and the nurses are inside, so they would take it in. So things like that, and addressing these things and talking to them. And we didn't have all the answers, but because we communicated, I think life did not come to a standstill. Our hospital did not have to close down for a single day. Similarly, surgeons had long times in an air-conditioned environment operating, so trying to see, what are the COVID policies kept on changing. So what if somebody had COVID in the past and needing a re-exploration, and would you test again? What is the duration of between two tests where you would consider something to be positive? This all required a centralized decision making, and there was a COVID hub command center who sort of amended the protocol based on the science and also the national government guidelines, the local guidelines. So life went on. The elixir of cancer therapy, chemotherapy in daycare, again, things, our data suggests that cancer patients actually wanted treatment. They did not want interruption in their cancer treatment. The third challenge was, once the waves reduced, getting back to normalcy. So, nurses were stressed, doctors were stressed, staff who had lost a near or a dear one. We have a few staff who had lost their parents, so that's difficult. So supporting them, and again, if you had developed COVID, you might have non-specific COVID sequelae, so diarrhea and things like that, and many of those staff actually got referred to me. So sometimes it just required some amount of reassurance and saying that this is not a psychiatric situation. You just give some time working together with the staff. I think that helped them a lot. Stigma is something which we did deal with in the initial part of the pandemic, and I have a small story. I remember I have a friend who is HIV positive, and she was positive 20 years ago, diagnosed to have HIV, and she was the first person who had called me in April to ask how was I, and I realized that that was a time in April 2020. A lot of health workers were stigmatized, being evicted from where they were staying, or the communities finding it difficult. It didn't happen in a very severe sense in our hospital staff, because we very quickly sort of got the administration and the security involved, and the local community leaders, and explaining to them that if there is any symptoms of the staff, they're tested free of cost. So they probably are one of the safest people to be useful in a pandemic when they are in the community and living there. But this is again something which worried, and you have to understand that there's no point in getting angry about it, because it's about the survival instinct, and many of these are unconscious processes. So we had sessions with laboratory staff, pharmacy, everybody. And if you see the first wave, this is again from a publication. So in a month, you could have 50 staff our hospital is not very big. We have around 1,000 staff. So, so 50 of them were positive. So you can imagine that the scare and the figures rising. September was the peak of the first wave. And the way we reacted to that was primary, secondary, and tertiary prevention, having COVID-19 policies, doing stress and anxiety management, handling stigma, sharing precautions when the people have shared accommodation. Not everybody, knows how to use PPEs. So training about PPEs, all this, if you do, it reduces the stress. Communication, again, for this is not only for our staff, but for everybody, but even staff, say a gardener who might be slightly elderly, they might not be, okay to be doing only online sessions. So we realize that, again, in a country like India, where it's easy to talk about delivering services online, but patients often require prior help before you become online with the technicalities. And one way I used was, I often told the patients that if they had somebody younger in their families who knew how to operate Zoom or WhatsApp video calls, we also reduced the duration of the sessions, because we realized that because the pandemic is changing very quickly, it's good to have frequent short sessions. Of course, people couldn't identify one from the empathy and the facial expressions. People couldn't identify their doctors and nurses. So these were real issues, and even the infrastructure of IT, that could be a barrier in terms of the connect. And of course, I have spoken about the complicated grief, and these were some of the issues in communication which we help. Dealing with anger of patients, dealing with anxiety of taking the infection home, this was universal for everybody. I think what if I have gone through this, and if I reflect about what happened, slowly things became better. Things became better before, the social distance, masks are essential. Vaccination, when possible, India has crossed apparently a billion doses of vaccination today, but the second wave had come down even before the vaccination had reached its peak. So for many of the countries in Africa where the vaccination cover is not adequate yet, I think you need to be reassured that things usually get better if you follow the social distancing and PPE and have adequate rest, and these sort of improved the even the mental health outcome. For we do run staff psychosocial services, so I have been treating staff for psychiatric illnesses for the last 10 years. It's a confidential service, but they do get help. So that went on, but in this pandemic we had additional ways to deal with the anxiety, because you can't just talk about depression in this situation. The other thing which the hospital did was, we did not have to luckily stop payment for any staff. In fact, in the first few months of the pandemic, the staff were paid 3 or 4 days in advance. So instead of the end of the month, they were paid around 24th or 25th. I think that boosted the confidence hugely. We also made travel arrangements when there was no public transport. Shift works only for few weeks. I think I did shift work only for a month. After that, we were there like regular time. Arranging stay when needed. I live a couple of kilometers from the hospital, so even walking it takes 15 minutes, and administration helping whenever needed. Uh, a beautiful spring did come after the COVID, and things are. There is a possibility that the cases have gone up a little bit in the last 3 4 days in India, but that could be because of public festivities. But from, say, in our city, from a new patient incidence of 20,000, now we are seeing 500 to 800 patients per day. So I think there is a silver lining at the end of the day. Thank you.
Thank you very much, Dr. Datta. We'll move on to the next presentation and we'll save questions for the end. But that was a great overview.
Hello.
Yeah, we can hear you now.
But can you see my slides, please?
Yes, we can see your slides. So you need to
Okay.
get to the start. Perfect. We can see it.
Yes. All right. Okay. Thank you. And thank you so much for that great overview. It really gives context to what I'm going to talk about. So I'll be speaking on the impact of COVID-19 on palliative care providers, sharing our experiences from Ghana. This is my facility, the University of Ghana Medical Center. You can see the emergency unit here where I spend a lot of my clinical time, and then the ICU is along this corridor. So this is what we'll be looking at, mental health challenges. I probably can skip that because the previous speaker shared that. Then challenges that we had are common reactions, impacts on us. All right. So in terms of the challenge, we all had to deal with a new normal. I think the first two cases in Ghana were on the 12th of March 2020. Prior to that, we had been preparing, we knew it was coming, and finally it got here. And we had to do with a lot of things differently. There was an initial lockdown in Accra, where I am, and another city, Kumasi, for 3 weeks, and all the changes that come. So for us working in palliative care, we had to learn to deal with this, the physical distancing, no touching, no social gathering. That, I think, was one of the most challenging things, because working in palliative care, your being, or yes, your very presence is part of the instrument you use to help patients. So suddenly there's a barrier, there's a physical distance, and you can't do that. And then the consequences of isolation. So you have patients who prior to this would have families visit, but now no visiting. So if the person was not an immediate family member, that created a problem. And then family members also lost their livelihood, and all of that affected the care that our patients were receiving. And then we also had longer working hours without adequate resources. So that was a direct impact of the COVID in Ghana. In terms of the increased distress, one of the first things was with stigma. Actually, when it came to repurposing of staff, because palliative care practitioners were doing home visits and provide supportive care, we volunteered, and even those who didn't eventually had to be repurposed to work with COVID patients alongside what they were doing. So the challenge of supporting patients who were isolated from family and friends was real, and adapting to changing clinical protocols. As we say, sometimes the information kept changing. So all of these things affected us. And for us, I mean, this is me in the PP in our COVID center. There was, we worked as teams, and one of the things we used to do well was really meeting regularly over snack, over food, debriefing, and providing support. That support was not there. Yes, we could do it online, but our times were such that even finding a common time where we could meet virtually was challenging. And we also had to find alternate strategies of caring for patients, and a lot of things were done on phone, and sometimes the phone calls could be overwhelming because this person is calling, that person is calling, and you needed to manage that. And when patients needed to be in hospital, finding beds for patients was challenging, because a lot of facilities were only doing emergencies. Patients who were already on the ward were okay, but new admissions had to be processed. You had to test for COVID, and before rapid tests, that could take about 48 hours. And between that time of the test being taken and the result, the kind of care that some patients received was not the best. And we also had to deal with families who were worried about their vulnerable patients who were in hospital getting COVID, because if you have cancer, most of the patients that we see, 98% of the patients we see have terminal cancer. And so with reduced immune systems, they were at a higher risk. And then the challenge with the protective measures, the constant awareness, the constant vigilance in terms of infection prevention control, the strict rigors we had to follow. I remember one time I was dealing with a patient who had COVID, who had come in with her husband, and the husband had died. She was weeping, rolling on the floor. Yes, I was in PPE. I wasn't fully donned, but I had my mask and a gown. And I remember the natural thing, because this is what we do if patients and families are distressed, we move towards them, touch them, help them find a safe space. This person was rolling on the floor, and I was moving towards the person without thinking about the fact that this patient had COVID and I wasn't appropriately done until someone screamed, shouted my name, Dr. Edwin, and then I literally stopped in my tracks. So those things were really challenging because it interfered with the care of patients as we needed. And then the fears had been mentioned, the fear of acquiring infection, because it was easier when you were working in a COVID designated facility, because there you knew that everybody you were seeing had COVID and you had the needed thing. But for most other general settings or the main hospitals where patients were not being seen, there that fear was real, because that is how a lot of people got infected, because lack of PPE. So at best you would have a surgical mask and you would do what you think you had to do. So then it got to a time the panic became more over and over. You can see the size of the COVID virus and then the two monsters, the panic monster, and the panic became a lot bigger to deal with. Then there was the uncertainty, of course, about the patient's status. If you didn't know, even if it was negative, people were not sure. And then there was also a shortage of staff who were doing the regular work because of the repurposing. And we had to deal with the fear of going home and infecting our families and loved ones with it, because being health professionals during the work lockdown, when most people, schools were locked down, nobody moving, and those of us who were working in health facilities were going to work and even spending longer at work. And then got to a time we had not just the stigma and discrimination from close, but even communities, several people who, especially nurses who used to wear uniform, had to stop wearing uniform because of the discrimination that they were facing. Even if you didn't work in a COVID treatment center, just the fact that you were a health worker, and a few, just like in India, lost their accommodation. So what was the impact of the pandemic on the palliative care service? So basically, I'm talking about our first wave and even the second wave now. So there was reduced OPD attendance because people, even though you would give appointment, people were afraid to go to the facilities, especially facilities that were also managing COVID, despite the fact that the COVID centers were in a specific units, people were just not attending. And then home visits, which was our number one seller, was actually suspended initially. And then after the lockdown, we started it, but it was limited. And so it became more costly because for the patients, before would have gone with a hospital vehicle and patients would just pay a minimum amount to the hospital. But now the hospital was not funding that. So if they wanted, then they had to pay for that cost, including the basic PPEs, depending if this was a critically ill patient whom you need to assess, because all the ambulances and everything was handling COVID. So people who did not have COVID but needed emergency care were falling through the cracks. There was increased teleconsultation, but the challenges have been mentioned in the first section. And then we also had residents who were regularly rotating with us, but that affected their training because the OPD visits were reduced, their home visits were removed. So the contact hours that they needed in terms of managing patients with palliative care was reduced. What was the impact on us providers? The main challenge really was a sense of disconnect from our patients. So we had a sort of session among ourselves to try and make sense of what we deal with. So most of these things are quotes from my colleagues. And I think it captures what we all said at the end. People were to write the experiences, and without conferring, we wrote similar things. So we felt detached from patients, as we could not touch or stay close to patients as we used to do. And that was very difficult. Personally, that was the most difficult thing, the fact that I couldn't be close to my patients, I couldn't touch them, that most of the care was done virtually or through teleconsult. Sometimes the phones were better, but the virtual ones where you could do video was what we prefer, but sometimes the network was bad and you couldn't see, and so you resort to just audio, and it made it difficult to explore or do a thorough assessment of our patients. wearing of PPEs made the situation worse as patients could not see the ones who were taking care of them. I mean, we look like people in costumes. When we visited patients, even the minimum they were supposed to have was a mask. So it made the interaction, as we saw in the pictures, the cartoons, very challenging. So one colleague put it this way, that being a palliative care practitioner during the pandemic was a torture, as we felt separated from patients who needed our love and support through their difficult moments. In addition, we previously, maybe for our palliative care clinic, we booked our patients and we routinely spend between 1 hour, 1.5 hours to 2 hours with a patient, because you don't only deal with the patients, you help the families who have questions, but we had to reduce that. So we spent relatively less time with them. And physical examination, as we used to do, was also because we were advised to limit contact or physical touch to the bare necessity. If, of course, the patient really needed to be examined, then you would have to do that. And the challenge is that we have patients who have mess to their lungs and come coughing. You've tested, they are negative, and yet on the side of the practitioner, it was also challenged, and even the supporting staff, that this patient is coughing. You try to educate them that it's because of the patient's primary condition and not because of COVID, but that also changed. So before the pandemic, we'll sit close to our patients on their beds to have conversations with them, also close, but that's changed. And because of that, the desired closeness, the connectedness, that's the word I was looking for, the connectedness, the fact that we are present with you and you are helping you through your journey, was not the same. We tried to get to it, but it wasn't the same. And then grief and loss was also compounded by the inability of patients to follow traditions surrounding death and dying. Funerals are a huge thing in Ghana. Process of mourning in stages, the immediate death, a week after death, then the funeral, the burial, and final funeral lies. But there was a ban on funerals. And when that ban was lifted, you could only have 20 or 25 people, gradually increased to 100. But it made it challenging initially because people just did not know how to transition. I think I've mentioned the challenges with the home visit, but one of the things that we, as I said, that home visits was really our selling point. It still is, but because we couldn't do home visits initially when patients needed care that ordinarily could have had to be had at home, it meant they had to go to the community facilities, and most of the facilities in the communities did not have people trained in palliative care. So you'd go, someone maybe who would just need a refill of morphine will not be able to access that, because in Ghana, prescription of morphine doesn't depend on the specialty of the staff. It actually depends on the facility. So you could be a consultant or a specialist in a tertiary facility, you are able to prescribe opioids, but the same person moves to a facility in the district, you cannot. So these were some of the changes, and patients whose pain had been controlled ended up having severe breakthrough pain just because they couldn't access that. So the stress that our patients and their caregivers experienced was also psychologically disturbing for us as team members. But then it wasn't all that negative. I mean, palliative care started in Ghana in August 2012. I mean, officially, before, we had nurses who were trained in palliative care and were providing that on their own. But the service in Ghana first started in my former hospital, Korle Bu Teaching Hospital, when we started rolling that. And we've had a challenging time trying to get people to come to us. Majority of patients that we see actually die within a month. We looked at our data, and 80% of the patients that we saw died within 2 months. And of this, 48% died within 2 weeks of referral. We've even had a few who get the referral by the time they get to us. So people didn't really understand that. It was confused with hospice, and even that they were not looking at 6 months, but just basically someone is dying and that's when you are referred. So we've been doing a lot of training and education, but because palliative care providers were actively involved in providing care for patients with COVID, not just in case management, but helping families and a lot of health workers who were infected or were affected by it, people began to see that we don't only have to deal with people who are dying, but we provide supportive care, pain relief, symptom relief. And so that was one thing that came out, and we had a lot of people appreciating our care, and that also improved our satisfaction with what we were doing. And as a result of that, people are aware, there's an increased awareness of palliative care thing. So how did we support our wellness, or how have we been doing it? It's been challenging, but then we look at two things. So what we required of the organization and what we required of us as individuals. So in terms of that, to limit working hours to no longer than 12 shifts. Most of us were not doing that before COVID, except maybe nurses who did night, and maybe if you were on call. But with COVID, things changed, so people were working longer, and sometimes I remember you could end up doing straight 16 hours or even 18 hours. So we had to make sure that we didn't do more than 12-hour shifts. We learned to utilize teams more. We dealt with teams, but we were assigned to places where people were used to working on their own as individuals. We brought that concept to them. Then frequent, clear, and rapid communication, appropriate provision of supplies and equipment, because you need to go into the center to provide care, but you don't even have an N95, let alone the full thing. So that was something that we had to make sure facilities provided. Then regular debriefing sessions were key, and we emphasized informal and formal support. In terms of the personal strategies, we needed to recognize and heed early signs of stress. We needed to reduce our tension, take brief breaks, maintain healthy diets. It's easier said than done. Avoid limits of coffee. That was it. I used to drink up to 5 cups of coffee a day, but at least I can say that for the past 3 months I've been off coffee, and I'm so happy with that. But learning to realize it's okay to say no. We had to draw our boundaries, because if we were stretched so much, we couldn't do that. And we shared our experience, supported one another, and asked for help. And for this particular day, the picture here was one day that was very difficult for me. It was early in our COVID last year. I think it was Good Friday 2020, where we lost a colleague who was also a friend and in our facility. And before I could even recover and deal with it and try and explain to people who were asking me for answers, another colleague also was diagnosed, and I was called to come in and talk to them, admit the person, provide support to their family. It was tiring, but at the end of the day, I felt that, yes, I needed time to grieve, but then I also needed to be there with others. And that is why supporting our wellness through talking to others and asking for help when we needed was really key. So I had a case, but I think I'll leave that for the discussion if there's time. So for me, I saw this cartoon. For the life of me, I can't remember where I saw it to give credit to the person, but it really speaks to my personal experience. And this is what it says. So that's my closing thought, that in the midst of an outbreak, there are people who will die in relative isolation from their family and friends. For those of us who have built our careers around the idea that people should be able to find peace, meaning, and connection in their last days, that prospect is gut-wrenching. All right, thank you very much. And these are the members of our team, some of them who were involved in these discussions. Obrigada.
Wow, thank you. That was very really excellent presentations. And I'll open it up for questions. And I think your quote at the end was also just sort of captured the whole thing for us in a very cogent way. So I have some comments, and I'll also allow other people to speak as well. So, Dr. Datta, when you were presenting, I think many times when we talk about healthcare workers, I think sometimes we forget about other people in the healthcare system that are non-doctors and non-nurses or non-clinicians. So I think it was interesting, how your organization really did think about all the people who are working within the healthcare system. And I think sometimes, clearly the challenges that each group of healthcare worker faces might be different, but I think those non-clinicians sometimes get to be left out of the thoughts and the conversation. So that's one comment. And I'll make another comment and then I'll let you guys respond. And, as both of you discussed, there were some themes that sort of came through. Certainly there were, challenges that the healthcare workers were facing, but also, some solutions that were sort of like organizationally based solutions to help mitigate some of those challenges. I think you mentioned things around communication, appropriate access to the wide amount of stuff that people actually needed to carry on their jobs. One sort of question I have is, at your institutions, have you seen any loss of healthcare workers as a result of the pandemic? Are people more likely to want to work at the hospitals, or how has that been? What's the experience along those lines at your institutions?
Yeah, but we were fortunate that we didn't have any staff of our hospital who actually succumbed during this period, but we had staff relatives. However, having said that, most medical communities are very sort of they are linked between one hospital and the other, and this what was particularly quite revealing to me was these WhatsApp messages in the beginning that 50 doctors dead in the country, 100 doctors dead, not being able to get there is a feeling that they were not cared for appropriately, or they were in the front line of the epidemic. So I don't know the truth. I have not been involved with any of these doctors who died personally, but I was directly involved. The effect of those messages on the morale of the staff, it was devastating. And I think that's what all pandemics have taught, that managing the mind is not easy, and fear spread faster than the pandemic when it was still happening in China and US, and people had not developed the testing probably in India, and were not getting enough cases. The fear had come earlier, and we were worried that if those developed countries have not been managing so well, how will we? So
Very much. So just like my facility, which is relatively new, about 3 years, we didn't lose any health workers. We got several people who got infected, but I personally had to deal with colleagues and their families who got who died. I initially was in charge of providing support, together with some other colleagues or doctors who got infected. So we were talking to them, providing support, but the death was not easy, especially I've worked in Ghana as a doctor for 27 years. So for those who died, I knew them. So it was personal. And as I said, even before you can process your own grief, it's as if people expect that you should be the one to provide support to others. So that period was challenging. I think one thing that the government did that has helped is to provide insurance for all health workers. And so people who got infected are giving some amount of money. Maybe it's less than 2,000, let's say about 1,700. So for any health worker who got infected, that is what the insurance will pay that for you, in addition to looking after you. For those who die, there wasn't any financial thing, but viral and support. But the fear was the main thing. Maybe it wouldn't have been that bad if there wasn't all the social media where at the click of a button, so much information, misinformation, disinformation. And my distress used to be health workers who have access to information, sharing some of these things. So what I used to say is, if you share it, you can't say you're just forwarding it, because you are a health worker, you are a health practitioner. So if you forward it to a platform where people who are there may not have the same knowledge, it's proven, because you are sharing it. So there's nothing like it didn't originate from me, I just forwarded it. That really contributed to some of the challenges. And so when people are there, you are talking to them, then the challenge, and even with health workers, I said, oh, you think this is all there is? Do you know the conspiracies? Do you know how people are? So it made the territory difficult. As he says, that dealing with the mind is not easy, having worked in mental health as well. So, but we're doing our best. And I think because of the insurance thing, you had to report when you got sick. Initially, people were hiding it, but for you to be processed, then it has to be seen through the system. So people talking, and those who need psychological supports are being provided. I hope it's made it easier. I hope. Thank you.
Any comments from anyone? I can keep going if no one else speaks up. So you guys spoke about, concepts around stigma, and the stigma the healthcare workers were facing. So in some settings, healthcare workers were seen as heroes of the pandemic. But on the flip side, you also mentioned that folks in society were seeing them as potential vectors of carrying the disease. So could you sort of discuss, that incongruence in a way, and how you think some healthcare workers were able to overcome whatever stigmatizing attitudes they were facing?
Thank you. So I think initially, so if you were a nurse and you wear a uniform or even scrubs, people in the community associate with you with healthcare. So some people were easily identified, especially if you're going to go and take public transport. There was the avoidance. Unfortunately, there were some people who were thrown out of the accommodation. They didn't even have to work in COVID centers. It's just the fact that you were a health worker and you work in hospital, you are bringing COVID home. I must say that the majority, at least the public thing, they heal people. But one of the ways people dealt with it was to wear mufti if you were a uniform person, and then you get to work and you change into scraps, so that one is there. And for those who lost accommodation, in my facility there was one, the hospital provided temporary accommodation for that. There were others also who opted to stay on the facility because they didn't want to go home, not because of stigma, but you don't want to, maybe you have a sick parent at home, you have young children at home, and you don't want to do that. But the stigma was not just from the general public, it was even among health workers. I remember once I had to go and be part of a press conference on COVID that was done. And after that, I went to one of our offices in our Ghana Health Service and saw a colleague who is also a doctor. So when I was coming, he decided to work with me and help me with my backpack. I didn't ask him. And he just, before he took it, he took tissue, was working ahead of me, took a pile of tissue in his hands and then held my backpack like that. And I was like, I had just finished speaking on stigma. You had listened to it. This is so stigmatizing. I haven't asked you to carry it. If you think that I have a virus on my back, why did you offer to do that? But to do that and to walk outside with me, you know, and it wasn't only him, it's the little comment. For me, it was easier to handle the public because I felt that my role was to educate them. But when people from the health professional community or health workforce acted like that, but it's also human nature. I mean, we stigmatize things we don't understand and discriminate because when you push it away, you feel you are safe. So it's constantly telling yourself that, hey, this is not it, and encouraging people and using it also as an opportunity to educate. But I must say that with the vaccine, at least where health workers have the option of being the first to vaccinate, I mean, people are less scared, I think, than before when we really didn't have that. Thank you.
Yes, that's a that's a nice example, and I just yeah, we are all humans, and all of these human things that that we do, and how that can impact the way we respond to other people. I think that was a good example. We're getting close to the end of the hour. I don't want to monopolize the questions. Any questions or comments from anyone? Everyone has been very polite, but thank you both for this like really insightful and great conversation and discussion. I hope everyone has learned something and picked up something from these conversations. So I'll pass it on to Christine, and if there are any announcements before we round off.
So thank you so much to our speakers today. We've learned quite a lot of information and we are grateful for your time. Thank you so much, Dio, for being an excellent moderator. We appreciate. Our next session is on November 18th, and we'll be talking about cancer economics. And we have a reason why we'll not have a session the first Thursday. We have AOTIC, and I think at this juncture I would wish to call upon Amaka to make the announcement about AOTIC. Thank you.
Thank you, Christine. Hello, everybody. And thank you to all our speakers. Very engaging conversations we've had today. I just wanted to, in line with what Christine said about that's first week of November, the African Cancer Research and Control ECHO, this community is actually partnering with the AOTIC to host a pre-conference workshop around implementation science, looking at the nuts and bolts of implementation science research on the African continent. So we just want to encourage all our members here present who are also members of AOTIC to look out for that session, and please be a part of it, as we really want to try to improve implementation research on the continent. And the conference actually it starts from 5th to 10th of November. So it's quite a long stretch, and we know that we don't want to overwhelm everybody, which is one of the reasons why we decided to push forward the next meeting on cancer economics to the 18th of November. So hopefully all of us will reconvene again on the 18th of November as we look at cancer economics in Africa. Over to you, Christine.
Thank you so much, Amaka. So Mishka, any announcements from your end, please? Okay, so Mishka says none, so I hand over back to the session moderator, Dio. Thank you.
So I think that is it for today. So thank you, Dr. Datta. Thank you, Dr. Edwin. These were really, really insightful. And thank you for sharing your thoughts with us. So If no further comments, I think we can call it a day.
Thank you.
Thank you. Bye-bye.
Thank you all.
Thank
Okay.
you. Bye, everybody.
Bye.
Bye.
So